All right. So central nervous system anatomy. We've got the central nervous system, which consists of the brain and the spinal cord, and then we have the peripheral nervous system, of course, that extends from that. There really isn't, we, of course, differentiate all the time between different components of the nervous system, but it really is a unified system to a great degree. So the artificial designations of one component and another are somewhat human caused. So we have the central nervous system, which is the brain and the spinal cord, and the peripheral nervous system, or the autonomic nervous system. The peripheral nervous system contains the autonomic nervous system, including the sympathetic and parasympathetic, and we'll look at those a little bit independently. And then the somatic nervous system that branches out into the motor neurons, which are the efferent neurons, and the sensory neurons, which are the ascending afferent neurons that come from the periphery of the body into the brain. The central nervous system, brain and spinal cord, we have the cerebral cortex, of course, cerebral hemispheres, one side and another. We have the brain stem, the cerebellum, the spinal cord. And so when we're navigating the brain, we need to understand directional terminology. If you're reading research articles, you'll be running into this directional terminology issue. And so let's take a look at that. The terms are varied, and sometimes we have multiple terms that mean the same thing. In the case of the fish, of course, we have dorsal, which is up away from the back. Medial is toward the middle. Lateral is away from the middle. Ventral is underneath or lower. Ipsilateral is the same side, and you'll see this when you look at electrode combination or montage placement directions. They'll say use the ipsilateral ear or the contralateral ear, which is the opposite side. We have a term called rostral, which is toward the front, and again we have medial and lateral. We have the midline, which we also have on the skull, and caudal is toward the back. But in the human, of course, we have dorsal, which is up or upper in terms of the brain, but since the brain is oriented upward and the spinal cord is oriented vertically, and the dorsal aspect of the spinal cord is directed towards the back of the body, then we have two directions for dorsal. So again, we have other terms. Superior is similar to dorsal. It's above or toward the top. And anterior, of course, is toward the front, which is similar to rostral. We have posterior, which is toward the back, which is similar to caudal. We have ventral, which is underneath or lower. And also, we sometimes use the term inferior to represent below or toward the bottom. When we section the brain, when we do slices of the brain, we have terms for that. So when we slice across the brain, that's a coronal section. When we take a horizontal slice through the brain, that's called a horizontal section. And when we slice from front to back, that's called a sagittal section. Various structural features of the cortex include septum, which is a wall between two cavities. A gyrus is a ridge on the cerebral cortex, and a sulcus is a fissure or a groove. And on the cerebral cortex, the sulci are the grooves between the gyri. So here's an example. Here's the precentral gyrus, which is the motor cortex, the postcentral gyrus, which is the sensory cortex, roughly speaking, of course. The central sulcus we have here. We have the superior temporal gyrus, so again that's a ridge on the surface of the cortex, and the sulcus is a space. We have the lateral or sylvan fissure here that separates the temporal lobe from the frontal lobe. Now we have designations where we consider this to be the forebrain. The forebrain is pretty much everything that we think of as the sort of working, active, conscious brain that we work with every day. The midbrain are other structures which we'll talk about. Midbrain here, and the hindbrain contains the pons, the medulla, the cerebellum, and other structures which we'll also get to. So let's start with the forebrain. The cerebral cortex includes functions associated with executive activity or decision-making processes. Personality, what we think of as our personality, the capacity for learning and memory, are contained in the cerebral cortex in its interaction with other structures. Sensory input, of course, and processing, the decision to make voluntary movements, speech and cognition, all of these are associated with the cerebral cortex. And that's broken up into segments including the frontal lobe, the parietal lobe, the occipital lobe, and the temporal lobe, and we looked at that when we were in class and looked at the different sensor placement locations. So we have FP1, or frontal pole, up here. We have the frontal sensors here, the central sensors here, which doesn't correspond with an actual brain location, except it is roughly over the sensory motor cortex, the motor cortex and the sensory cortex along the central sulcus. The parietal lobes, so the P electrodes, P3, PZ, and P4, and so on. We have the temporal lobes, so the temporal electrodes, and the occipital lobe back here. So the frontal lobe contains the functions of memory, but memory is a distributed function, so it's more that the frontal lobe is more involved in the decision-making process that is associated with memory. We have personality, mood, and empathy, planning and judgment, executive function, will, volition, and choice. And the dominant hemisphere contains Broca's area, which we will see in a bit. And that's concerned with the motor component of speech expression. So frontal lobe functions including motor control, control of skeletal muscles, voluntary motor activities, gross and fine motor control. That's all contained in the frontal lobe. So here's a picture of Broca's area. It kind of underlies the F7 electrode if you were to think about training this. Broca's area is associated with the creation of the motor template for speech. So Wernicke's area determines, or in conjunction with various network structures, of course, determines what we're going to say, the content that we're going to talk about. And then it's projected to Broca's area where the motor template is worked out. How do we actually produce that sound? And then that's sent to premotor areas, and then finally the actual motor commands are sent to the motor cortex, and we have actual speech. So it's a fairly sophisticated and complicated progression from Wernicke's area, well, from frontal cortex structures that determine that we want to say something and that make some commands about speech, but Wernicke's area is where we create the content of that speech. And we know this because when we work with individuals who have had lesions in these areas, we know that lesions in these areas leave the person often able to produce speech that sounds reasonable, may have an appropriate verbal expression, but it's nonsense. It doesn't make any sense at all. So the content is skewed. And also people with lesions in this area, this Wernicke's area, often have a difficult time deciding what to say, and sometimes they have both receptive and expressive aphasia where they can't process incoming information and extract the information from it, because Wernicke's area is also involved in the perception and processing of incoming language-based or communication-based information. But if we have Wernicke's area intact and we have damage to Broca's area, what we'll have is the person will say, I know what I want to say, but I can't say it. I can't get it out. I can't produce the speech sounds. And so when they talk, it sounds like complete nonsense. but it's the kind of nonsense that's associated with lack of ability to create the motor template correctly. So these are just some of the structures, and of course language is also a distributed function because it relies on the network communication system to determine what we're going to talk about. Here's the areas inside the lateral sulcus or lateral fissure, and this used to be called the gustatory cortex and is actually still labeled the gustatory cortex here. We'll talk about that a bit later. So motor control is associated with the motor cortex, and damage can cause loss of muscle control on the opposite side of the body, generally speaking. And depending on the specific area, it can also affect the ability to speech, because you can have the content, you can have the motor template, but if the motor cortex functions that drive the larynx and the lungs to push out air through the larynx, and the tongue and the lips that produce that form, and the mouth that forms the speech syllables isn't working, then you'll still have problems with speech. Here's a schematic of the brain areas involved. This is the motor cortex, and this is broken up into the segments showing the areas involved in controlling the motor function of each of these areas. So the swallowing function actually gets a fairly large area of brain real estate. The tongue, the jaw, of course. The lips get a significant amount of brain real estate because they're intimately involved in the speech production process. So this is not sensory, by the way. This is motor control of the lips. And clearly the fingers and the thumb get a lot of real estate compared to the size of the area, of course. And whereas the trunk of the body really doesn't get a lot of motor control function because it doesn't require a lot of fine motor control. Whereas things like the ankle and the toes and the knees, they get a fair amount of brain real estate assigned to them because they're more important for walking, gait, and other kinds of functions. If you do a search on the internet for a motor homunculus in the human, you'll see a body representation, a little man, a homunculus. The term homunculus means little man or little person. You'll see a representation as a body, a little guy who has huge lips and a big head, and other parts of his body are really small in terms of the trunk of the body is very small. You'll also see the similar representation for the sensory homunculus. We talked about Broca's area already. I obviously got ahead of myself a bit. So we've already talked about that. The parietal lobe contains the somatosensory cortex, and it is the area that processes and integrates perceptual and sensory input. So it processes the sensory input, and here we have the somatosensory cortex represented. Here's the location, posterior to the central sulcus, and broken down into the different segments. And of course, again, we have sensory processing, a lot of sensory area associated with the foot, for example, and of course the face and the lips, again, get a lot of real estate. The tongue gets a lot of sensory real estate. But again, the trunk of the body doesn't get a lot of sensory real estate, comparatively speaking. Whereas the fingers and the thumbs, of course, requiring lots of sensory input, get comparatively larger areas. So now this area is not just processing this information. One of the other things that it does is that the parietal areas have a function of that are posterior to the somatosensory cortex, have integrative areas that integrate other sensory inputs, including auditory and visual. And also we have some working memory structures under the P3 and P4 electrode locations. So this is pretty much under the C electrode locations, C4, CZ, and C3 over here, whereas in the parietal locations we have more integrative and memory areas. In the temporal lobe we have perception of smell, taste, and hearing, structures affecting memory and mood and personality. Wernicke's area, again, in the dominant hemisphere that we looked at already. Wernicke's area, we also talked about this already. And I guess one other function that is involved with Wernicke's area and Broca's area is stuttering. When you have damage to an area, you can have problems with stuttering. Either of these areas, you can have problems with stuttering, and training between the two areas can often resolve that. So one of the things I've done with people with stuttering problems is train between the two areas. So usually the sensor at T5 and F7 and communicate between those areas. But if the stuttering is associated with problems communicating between, for example, Broca's area and the motor cortex, then it's more of a process of training between F7 and, for example, CZ or FZ. By the way, if you folks have, because everyone is muted because otherwise it's just too confusing, if you have any questions, be sure to write those down, as I mentioned in the email, and save those because we'll have a question and answer session at the end of this presentation. So in the occipital lobe, we have the primary visual cortex, where damage can cause partial or complete loss of sight, and defects in the initial stages of visual processing can occur as well. Confusion of inanimate objects with faces and so forth. So let's review that a little bit. We've got the cerebral cortex, the motor cortex, the somatosensory cortex, the secondary somatosensory cortex, the prefrontal cortex, the visual cortex, the auditory cortex, and the insula. Now the insula, again, as I showed you, is inside the lateral fissure. It's buried fairly deeply inside the interior to the temporal lobe, and it's involved in emotional and autonomic responses to external stimuli, and it's also part of the salience network, which we'll talk about a little bit more. It's loosely broken up into two structures, the anterior and posterior insula, but each of those has individual nuclei that have different tasks associated with them. So the salience network is a combination of structures including the insula. It also involves the cingulate gyrus, and particularly the anterior aspect of the cingulate gyrus, where it's associated with detection of salient events via the afferent pathway. So we have these incoming sensory pathways that we talked about at the very beginning briefly. And how do we determine what's important about those incoming sensory inputs, and what should receive our attention and what should be ignored? And so the insula is part of that monitoring system. It's directly linked to the limbic system as well, and it has interactions with the basal ganglia, for example, including the thalamus, and the input-output functions are partly mediated by this interaction between the insula, the frontal lobes through the anterior cingulate, and so there's this monitoring process that occurs, and the insula then is integrally involved in switching between various attention networks, the dorsal and ventral attention networks, for example, and the default mode or resting state networks. one of the ways that the insula is involved in this is regulating the autonomic responses to these incoming stimuli. So it has a function where it prepares the body for action, if you will. And it also has a function that facilitates the ascending alerting pathways that get the cortex ready for incoming sensory input that needs to be processed immediately. The insula is considered an integrative mechanism, or has an integrative function, and it organizes. It's like a hub for the salience network. It also integrates interoceptive awareness, so it's not just perceiving external sensory input, it's also in receiving information about internal sensory activity. And that's why it was originally called the gustatory cortex, because it was supposedly thought to be only related to a gut-level sensation. So the sensation of being full, for example, the sensation of your stomach being upset was associated with the insula initially, before its comprehensive function as a general organizational structure for sensory input of all kinds was understood. So it's this mechanism that helps us determine what our relationship with the world is, perceive ourselves in the world. It's a fairly fascinating structure. Now, one of the things that has guided us in this process of understanding the brain and the nervous system has been the work of Corbinian Broadman in the early 1900s, where he was an anatomist and went through the tissues of the brain in great and exhaustive detail and mapped out the different kinds of tissues and how they differed from each other. And he created a zone arrangement of 47 different numbered zones with distinctive anatomical characteristics. And we continue to use these designations. And so here's an example of Broadman's map overlaying a cortex. Here's the interior aspect of that, and a sagittal section. Remember our sections, front to back section is called the sagittal section. So each of these areas tends to have a fairly unique or different architectural structure, and they do tend to loosely correlate with the structures of the brain that we have come to understand as having functional characteristics that differ from their neighbors, even if they're adjacent as well. Now, when we get to subcortical structures, we have structures including the cingulate gyrus, the parahippocampal gyrus, the corpus callosum, basal ganglia, hippocampus, insula, fornix, amygdala, thalamus, hypothalamus, and pituitary, and we'll go through those one at a time. Here they are, some of them at least, showing again in a sagittal section, showing the right hemisphere from the interior aspect of the right hemisphere. So we have the cingulate gyrus running from front to back, the anterior and the posterior cingulate having somewhat different structural characteristics and task orientations. We have the corpus callosum, the communication fibers between the left and right hemispheres. We have the fornix here, which also has communication pathways between the hemispheres. Here's the olfactory bulb up here, the optic chiasm. Here's the cerebellum as well. The medulla, the pons, the tectum, the tegmentum, the hypothalamus. The thalamus here, of course, is a paired structure, two of them, one on each side. The pineal gland, pineal body. Here's another view of that, and note particularly the cingulate gyrus and the parahippocampal gyri. over here, as well as the isthmus of the cingulate gyrus. And just another slice, a sagittal. Not a sagittal. Yeah. So let's talk about the cingulate and parahippocampal gyri. There are reciprocal connections between the cingulate and the parahippocampal gyri. This is an interesting relationship, and actually the cingulate gyrus is it's this pathway. It's a highway of network communication pathways that travel from subcortical structures primarily to cortical structures, and so it's one of the most important pathways that we have in terms of communication from subcortical to cortical and from posterior to anterior as well. So there are reciprocal connections with underlying structures, including the parahippocampal gyrus. Again, that's a paired structure, and the parahippocampal gyrus is associated with all sorts of interesting functions, including memory, spatial orientation, emotional responsiveness, and it isn't where memories are located, but it contains the template for where memories are located. It appears to have sort of a card catalog or a location-specific function. So if areas of the hippocampus, for example, are damaged, we can lose access to memories. Even though the memory areas probably haven't been damaged, we don't know where those are or what combinations of neurons need to get together and oscillate in a network structure, as we talked about in class, to retrieve that memory. The parahippocampal areas are involved in that organizational mechanism. It also is involved in both spatial orientation and memory of spatial orientation. So, for example, studies, imaging studies and also autopsy studies of London cab drivers have shown that the hippocampus itself grows and becomes more complex as the cab drivers are on the job for a longer and longer period of time, memorizing the street grid of London, which apparently is very complicated. And so it embodies the spatial orientation and awareness functions to a great degree. And so if a person has a difficult time finding their way in the city or anywhere, it may be that this isn't functioning quite right. It's also involved in parsing what type of emotional response we're going to have to a particular situation. Now, it communicates up through the cingulate gyrus and into the frontal lobe structures of executive function areas through the cingulate. And the cingulate itself is involved in, and this is through a variety of primate studies, child nurturing, play behavior, grooming behavior, but it also, in the human particularly, is the organization and management hub for input-output functions. So it's a pretty important structure. Now, the basal ganglia is a loose term that really means a bunch of different structures, but altogether they regulate output from motor output from central nervous system and work together to produce smooth, controlled movements. But they are clearly involved in many other things because it involves the amygdala. We have the thalamus, the lentiform nucleus. So we have multiple structures that do other things as well. We've talked about the thalamus having a primary input-output function as well. We have the caudate nucleus, which is this communication pathway between these various structures. And so it's a much more complicated grouping of structures than it was originally thought to be. The hippocampus and the fornix, we already talked about the hippocampus to some extent. This connects the cerebral cortex and the rest of the forebrain We have control of response to stimuli. We have sensory experiences into the context of past experiences, important connections with the limbic system. It's important in memory formation and retrieval and other functions as well. The fornix connects the hippocampus with the cerebral cortex. It's a major route for the flow of information within the limbic system, and the two halves of the hippocampus on either side of the midline are also linked together via the nerve fibers of the fornix. So here we have the commissure of the fornix. When you see the term commissure, you know that that means that these are fibers that connect the two hemispheres, or the two sides of a paired structure. And so an example is, we talked about the hippocampus, and here we have the amygdaloid bodies, the mammillary bodies, and all of these interact in this mechanism throughout through this communication pathway called the fornix. Now the thalamus lies above the hypothalamus, and the two structures comprise something called the diencephalon, although they have independent functions as well. It's a paired structure, of course, again, as we said, the left and right. One of the most important gateways or pathways, input-output pathways in the brain between the cortex and the rest of the brain, the peripheral nervous system, the motor system, motor commands, all of this goes in and out through this pathway through the thalamus. Each thalamic structure contains multiple nuclei which independently interact with various areas of the cortex. So here's where the thalamus resides. Again, it's a paired structure. There are two of them, one on either side. The hypothalamus resides underneath that. Here's the insular cortex right here, and there's an interactive mechanism between these. The thalamus has various nuclei, as I mentioned, which project to cortical areas and are identified very precisely, actually. Now, the hypothalamus is also a very important structure, and it does some very interesting things. It lies below the anterior end of the thalamus, and it has several nuclei of its own, of course. And those control hormonal systems, but they also have a monitoring function. And so the hypothalamus monitors the body and determines what's missing, or what it needs more of, or what it doesn't need so much of. And so it tells you when you're thirsty. It tells you if you need to eat. Regulates body temperature. It is intimately involved in craving mechanisms and craving behaviors. So when you crave something, let's say the classic of the pregnant woman who craves pickles and ice cream, well, there's the hypothalamus is involved in that. And anytime we have a craving, it's likely that we're missing something, or that we have the higher brain functions that are calling for something that trigger a particular response. And the hypothalamus is responsible for those craving experiences. So when we have drug addiction, for example, the hypothalamus is very much involved in the craving behaviors that are associated with drug addiction. The hypothalamus is also responsible for the hormonal aspects of the fight or flight response, so it triggers the hormonal discharges that result in that readiness and arousal mechanism that get us ready to fight or run away. It's also involved in sexual activation and response. It's involved with emotion and motivation. And it's connected to the pituitary gland, of course, by nerve fibers and by the hypothalamic pituitary portal vessel. It gets nerve inputs from sensory nerves, limbic system, internal organs. It's a very interconnected structure, interestingly enough, for something that's so small. And here's a schematic of the nuclei of the hypothalamus. You can see there are multiple nuclei that do lots of different things and interact with other structures. Now, the pituitary gland responds to stimuli from the hypothalamus and from other structures to some degree, and releases hormones that regulate all sorts of things, including body growth, and regulates other glands and organs. It receives the hypothalamic hormones, which trigger the release of other hormones. It's a pretty vital link between the body's two communication and control systems, the nervous system and the hormonal system. So how does the brain get the body to act? Well, it goes through the hypothalamus and the pituitary gland, and it triggers those actions. The problem with that is that the actions are fairly slow and fairly gross in terms of being kind of an all or nothing kind of thing, not well regulated or mediated by the central nervous system. So there's not, I mean, once you get a dump of hormones that trigger the fight or flight response, it's not a modulated response. It's pretty much an all or nothing response. And the other problem with it is that it's hard to turn off. Once you dump those hormones into the bloodstream and into the endocrine system, you have a fairly long period of time that they remain active until they're metabolized and removed. So whereas we can have a thought that takes a very short time to occur, and we can start a thought and maybe come to a conclusion that's incorrect, and then fairly quickly determine that it's incorrect and then respond differently. When we have determined something is dangerous and we've triggered a fight or flight response, that's something that doesn't go away in a quick hurry. It takes quite a long time for that to go away. So one of the consistent difficulties with that situation is that sometimes people have this tendency to perceive the world as a dangerous place all the time, and so they're constantly flooding their body with these activation hormones that don't metabolize very quickly, and they hang around for hours and hours in some cases. And they are also a finite resource. And when they're discharged over and over and over again, then they become depleted, and it's no longer a possibility to activate those responses because the hormonal substances have been depleted. So it's something to keep in mind when you're working with somebody who has, for example, a panic reaction, and just keep in mind that once that panic reaction is triggered, you can teach them to relax in the moment, but that doesn't change the fact that their body is still in the grip of these hormones, and that's going to take several hours to clear. And it's also good to educate the client about that as well. So here's a schematic of the pituitary gland, and again, it projects out to other structures through its release of hormones, and there are multiple different hormones that it releases, and so that's a study all in itself. When we get to the midbrain, we have the tegmentum, which is associated with nerves that innervate the muscles of the eye and are responsible to some degree for the directionality of our gaze, where we look. Interestingly enough, is controlled to some degree by this sort of midbrain structure. And it's composed of two structures, the substantia nigra, which is a pigmented nucleus, and it's part of the basal ganglia that are involved in the control of movement. And so these are more reactive or reflexive mechanisms that control some pretty basic functions. The red nucleus is part of the reticular formation. That's not the reticular nucleus of the thalamus. This is the reticular formation of the brainstem. And it interconnects hindbrain, midbrain, and forebrain structures. The tectum forms the roof of the midbrain, and each tecta contains two regions called the superior and inferior colliculi. The superior colliculi receive information about visual, auditory, and tactile stimulation, and they control the movement of the eyeballs as well. Head and neck response to visual stimuli. And again, these are very reflexive responses. These are not cognitive responses. And so we move our head in response to sounds that are probably below the level of our conscious auditory perception. We move our heads in response to sense of smell information that doesn't even go through the thalamus, but goes directly to the amygdala, and then triggers these responses, and also other kinds of sensory inputs that are often not consciously perceived. Now, this area does have extensive connections to and from the cerebral cortex via the thalamus, and to and from the cerebellum, and of course we'll talk about the cerebellum in a bit, about its role in movement. The inferior colliculi are involved in processing information from the auditory stimuli, and again this is what I was just talking about in relation to responses that are subconscious. So here's the tectum, the superior colliculus and the inferior colliculus for visual input and auditory input at a very basic and reflexive level. Here's the tegmentum over here. The hindbrain, we'll start with the pons. The medulla, the reticular formation is kind of a loosely grouped combination of cells that have integrative and control functions at the brainstem level. We're talking again about very reflexive responses, and then we have the cerebellum over here. The pons is a bridge. It refers to the bridge-like appearance created by the transverse pontine fibers that links the medulla and the midbrain, and it conveys information from the cerebellum, the cerebrum, to the cerebellum, and there's some aspect of respiratory control here as well. So even if the respiratory function is inhibited in the cortex itself, in the brain, the pons can maintain respiratory function even if the person is brain dead. They can continue to breathe to some extent, as long as the damage doesn't reach this level. If the damage reaches this level, then it's probably pretty difficult for the person to breathe independently. The medulla has nuclei control that regulate heart and breathing rates. Again, these are very basic functions. Blood pressure, coughing, sneezing, swallowing, vomiting, all these are to some degree controlled by structures that reside within the medulla. And the reticular formation, as I mentioned, they have extensive connections to all areas of the brain, and it's an information flow regulator at a very, very, very basic level that is completely non-conscious. So again, it's at a basic level of reflexive response to incoming stimuli that is intense or unique enough so that it triggers this projection to the cortex, and it involves us in responding to those. Now, the cerebellum is an interesting structure that doesn't produce external fields, electrical fields, that we can record with the EEG, but it does have various types of neurons within it, and it has all sorts of interactive functions, and it's particularly associated with the execution of body movements, balance, posture, that sort of thing. And if you have somebody who has a difficult time walking or moving because they've had a stroke, sometimes training in the area of the cerebellum, even though it's not something that produces EEG fields, can be very helpful in helping people restore their ability to walk correctly and balance and maintain an upright posture. So that's generally the central nervous system components, but let's talk a little bit about the peripheral nervous system, and then we'll have some time for some questions. Here we have the peripheral nervous system. We have the somatic and autonomic structures. Now, the somatic or motor fibers tend to not synapse between the central nervous system output structures and the actual muscles. So they terminate at the skeletal muscles without any synapses in between. So it's a pretty direct response system, pretty quick, doesn't take a lot of time. except for the time it takes for the message to get across this long distance pathway. Now, some of these fibers are quite long, a meter long in some cases, and so that's a pretty long fiber. The autonomic nervous system fibers, generally synapse in various autonomic ganglion, and we have the preganglionic fibers and the postganglionic fibers, and these terminate in smooth muscles, cardiac muscles, and gland cells. So these help regulate cardiac function. It helps regulate the contraction and opening of the smooth muscles, particularly those surrounding the blood vessels. So it has a direct role in vasoconstriction and vasodilation in the periphery of the body. Skin, for example, and it's associated with innervation of gland cells as well. Here we have it laid out in the structures. We have the parasympathetic nervous system, which comes out quite early and then branches off from one output or just a couple of outputs up here at the top of the spinal cord, and then progresses out through this pathway to these other areas of the brain, areas of the body, regulating digestion, constricting the bronchi, for example, inhibiting the heartbeat, stimulating salivation, constricting the pupils, whereas the sympathetic nervous system has outputs all along the spinal cord for each of these functions. It's much quicker because it's involved in the fight or flight response. Of course, it's important for it to have quicker pathways to these areas. And so we have dilation of the pupil, inhibition of salivation, relaxation of the bronchi, acceleration of the heartbeat. All of these, of course, you have to think about in terms of the fight or flight response, getting us ready to fight or run away. So stimulating glucose release by the liver, which, by the way, can affect diabetics and contribute to type 2 diabetes, for example. Secretion of epinephrine and norepinephrine from the kidneys, relaxation of the bladder, and contraction of the rectum. So all of these are interactive functions. So, for example, heartbeat is an interactive function between the parasympathetic and the sympathetic nervous systems. And so we have to have a nice balance. If we don't have enough activation from the sympathetic nervous system, our heart won't beat fast enough. If we have too much activation, our heart's going to beat too fast. If we have too much parasympathetic innervation, we're going to have a constriction of the lung bronchi. We're going to have a difficult time breathing. That's why when people have an asthma attack, they give them stimulating hormones like epinephrine and norepinephrine to stimulate the relaxation of the bronchial areas, because that's necessary for getting more oxygen in when you're fighting or running away, for example. So this is a fairly quick overview of the central nervous system and the peripheral nervous system. I'm going to unmute everyone. So in terms of terminology, if you're interested in terminology, on your flash drive that you got in class, there is a document that's a very comprehensive neuroscience glossary that goes through all of this terminology in some detail. And there are also, of course, lots of articles and papers on this area of interest. So looks like we've had a couple of additional folks join us since we originally started. Shanta, hello. And let's see who else came on. And you guys are all unmuted so I can hear you.
Hi.
Hi.
Stephanie.
Hi, Stephanie. Any questions from this particular presentation?
If I wanted to help someone with posture, where on the cerebellum would I place the sensor?
Good question. The protocol was actually developed by Margaret Ayers way back, and Corey Hammond has also promoted it. Where you place the sensors is right on the Inian ridge, which is at the bottom of the skull. Right at the bottom of the skull. It's below O1 and O2, right at the ridge. So when you're measuring from the Inian to the Nasian, for example, and we measure the Inian at the bump at the back of the skull, well, it's along the Inian ridge that is kind of at the same level. And usually it's done as a bipolar montage, so a single channel with the active and reference sensors on this Inian ridge, one on the left and one on the right, which is just below O1 and O2. And then the training protocol is to reward beta, 15 to 18 hertz beta, and inhibit theta and inhibit fast beta. And the ground can go on O1 if you like, or wherever in the back of the head. And so it's 3 sensors, and they're all in the back. And it actually is fairly a positive response. I've used it with quite a few stroke and traumatic brain injury clients that I've worked with. And it does seem to improve their gait and their ability to walk without support. I've had people starting out in wheelchairs ending up walking with a cane or a walker. Certainly it doesn't resolve it completely, but it does seem to improve it substantially. Other questions?
If we wanted to train the insula, what placement?
Well, the insula is kind of in between the F7, F8 locations and the T3, T4 locations. So when I want to train the insula, I usually do it with Z-score training, and I usually do a 4-channel arrangement at F7, F8, T3, T4. That's kind of how I've been doing it so far. It's probably more interior to the T3, T4 locations, but it extends anteriorly to some degree as well. So it's a little bit tricky to get at it. If you really want to get at it, the best way is to do 19-channel Loretta Z-score training, because 19-channel Loretta Z-score training does actually see the insula and can train it, at least train the surface manifestations of the activity of the insula. Other questions? Question about teaching breathing. Teaching breathing is a little tricky. When I teach breathing, I use my BioTrace system, and I hook up the respiration band around the lower rib cage. Now, a lot of people hook up the respiration band around the navel, which is okay, but I like to have it up a little higher than that. And so I like to be kind of between the navel and the solar plexus, if you will. So right over the lower rib cage, or just below the lower rib cage, is the preferred location for me. Because what I'm trying to teach is that the lower rib cage expands when the person inhales and then contracts back in when the person exhales. And I always describe it to clients as though it were a balloon in your stomach that's expanding when you breathe in and it's contracting when you breathe out. And most people get that idea. And then I also use the heart rate measure, and I show those both on the screen at the same time, so the person is seeing their respiration tracing from the respiration band that's around the lower rib cage. And they're also seeing the change in heart rate, the respiratory sinus arrhythmia heart rate change. That is the response to respiration, and I teach them to get that to superimpose one over the other so that they're synchronous as much as possible. And that's usually something that's pretty easy for people to figure out. I actually had a client recently, the first client I've ever had, that really just could not get it. And it was unusual because most of my clients get it pretty quickly, but this person just could not get that to synchronize at all. And I think she was really thinking about it a little bit too much and not just experiencing it. The other thing that I do is I send home a respirate device with people, and that allows them to practice at home. There are other devices that are useful. The heart math devices that are out there are pretty useful as well. The nice thing about the respiratory, well, two nice things about the respiratory. First of all, it's FDA approved for blood pressure regulation. So if the person has high blood pressure, they can usually get it paid for by their insurance company because it is an actual FDA approved product for blood pressure regulation, and it does work really well for blood pressure regulation. And the other thing is that it's so easy to use and it doesn't require a computer connection. So people can just push the button and it starts right up and teaches them how to breathe correctly. Other questions?
For some reason, I've got a big influx of clients that want to work on libido, and so I had pretty good luck using the homunculus sites for people with pain, like elbow pain or wrist pain, and I look at the Broadman area. I guess I'm looking on page 40. One of these, page 40. You have the somatosensory cortex with the genitals below the toes, and I was wondering what placement would I use to get to improve the sensory influence there.
That's the motor. There's the sensory. Well, again, this is inside the sulcus, the central fissure, and so it's pretty hard to get at. You'd be thinking maybe CZ. Otherwise, I don't see how you'd get at that unless you want to stick a probe down in there in the middle of the brain, which is not possible, of course. So I'm guessing you're probably going to want to be working on the, at CZ. Now, the motor really doesn't have an area associated with that, at least in this particular view of it. So I think, now libido, of course, is a multifaceted issue, and it's also involved with hormonal regulation. So then if you want to think about hormonal regulation as a component, then you're thinking about really deep structures like the hypothalamus, which is not...
Sorry. I should mute myself.
Yeah, or stop that replay on the internet. You're looking up the respirate, I suspect. So, looking at the hypothalamus, there's just no way to get at that directly.
We had a presentation at the AAPB annual conference here in Austin a couple of weeks ago on how heart rate variability biofeedback helped vaginal secretion and helped with female sexuality, doing heart rate variability biofeedback. So maybe with males, I can do the same thing.
Well, it's definitely true that relaxation has to precede sexual arousal.
Okay.
So that makes a lot of sense. We all think that sexual arousal is excitation, but it really requires relaxation to begin with. And so that's definitely a component. That's an interesting thought. Other questions? Okay. Apparently not. So it's about 10:20, and let's take a 15-minute break. We'll come back at 10:35. I'm just going to mute everybody and stop the recording, but I'm going to let the meeting stay open. And so we'll come back at 10:35 my time. That's Central Time. So right now it's 10:20 my time. So in 15 minutes from whatever your clock says, come on back and we'll start up again. Okay? And now I'll be... Okay. So now we're recording. Okay, so exam questions. So the exam used to be heavily weighted toward EEG technician sorts of questions, and they were some sort of arcane or old-fashioned EEG technology questions like, you know, what channel do you plug in the active and the reference? Well, pretty much no system in existence right now uses that approach. In the old days, you had to physically plug in the active, the reference, and the ground as individual separate cables. And if you wanted to change the montage, you had to change things by plugging different cables into different ports. There was no switch function that would allow you to do that, and there was no automatic software-based function that allowed you to do that. And the fact that no system currently in use even does that means that we shouldn't have those kinds of questions in the exam. But the people who write the exam, a lot of them were kind of old-timers, and so those questions crept in. So you may still run into questions like that. There are a fair amount of technology questions about EEG technology in general, and about waveforms, and about filters, and so you're going to get a bunch of those. As far as your question about anatomy and physiology questions, there will be a representative sample, and they change that every time. They have a huge bank of questions, and they select from those questions somewhat randomly to make up each individual exam that they administer, so no two exams are exactly the same. So you don't know which anatomy and physiology questions you're going to get on any particular exam that you might take on any given day. So that's the kind of the difficult part, but it also ensures that people make a comprehensive study. Now, if you review this presentation, it's highly likely that you'll have what you need to pass the exam, the anatomy portion of the exam questions. It's probably not going to be more complex than that. On your flash drive, there are, this presentation is on your flash drive, but also on your flash drive is a presentation on cellular anatomy, and we didn't go into that. And but you will get some questions about cellular anatomy and ion transport and those functions that are associated with the production of the electrical activity that we measure as the EEG on the scalp surface. So yes, you definitely will get some questions that are at the level of cellular anatomy, and so I recommend that you review that presentation that's on your flash drive, because that's very comprehensive and goes into quite exhaustive detail about that. I had another question. Somebody asked about, do my clients do the respiration training? Oh, what's the title of that presentation? It's called, let me see, I can actually look it up here.
I got it.
What's it called?
CNS, structure and function of CNS, structure and function of CNS, and it's in the presentations directory.
Right. Let's see. Yes, right. Here, I'll show it to you just briefly. There you can see it on my screen. So it starts, and so it's this same presentation, but it also contains, I think, well, it's a little bit more, well, no, that's not the one I was thinking of. The one I was thinking of was the origins of the EEG. That's the one I was talking about. The origins of the EEG neuron at the neuron level. So it talks about the different types of cells and how they interact and process the data, and ion channels and synaptic potentials, and it goes into great detail about all of this stuff. So I recommend that you review this one as well. So the name of that again is the origins of the EEG. Yeah, so let's go back to the second screen. There we go. So the question was, do my clients do the respiration and heart rate variability training during the session? They don't actually do that during the EEG training session, but they do usually do that at the beginning of training until they get it, until they can do it independently. So I'll usually start out with that. I'll train people with that to start with, and then as they're progressing through the training process, I'll check on them every once in a while just to make sure they've got that and they understand how to do it. And once they really get it and they have it, so I rent the Respirate to them. They can buy it if they want, but usually I rent it to them for 3 or 4 weeks, and then they bring it back, and once they've figured it out, they can do that independently. They don't need a device. If they want to buy a device, they certainly are welcome to do that. Any other questions? Okay, well, I'm going to try this again. I've got a recording of the next presentation, so I'm going to see if I can make that work. But if it doesn't, I've got the presentation ready to go, so I'll just do it that way. I'm going to mute everyone. And so let me get set up with that, and we will see if it goes, and if it doesn't, I'll just present it directly. This presentation is about professional conduct, but also about guidelines for conducting training, and which clients are good candidates, which clients are not good clients to start with, and we'll go from there. So the thing about neurofeedback, and actually there's been a discussion on one of the internet discussion lists that I'm on about a new licensing law that's trying to make its way through the New York State legislature, licensing neurofeedback therapists, not biofeedback, but specifically neurofeedback therapists. And the requirements are pretty minimal, actually. I think they're asking for 50 hours of training, and I don't know that they're asking for any particular requirement in terms of experience or supervision or anything else, or licensing requirements. So one of the things that we're going to talk about here is what kind of requirements should be in place for a person to practice any type of biofeedback, including neurofeedback. One of the issues about neurofeedback is that it seems to work for a lot of different things, and it seems to be quite helpful, and it doesn't seem to be too difficult to apply once a person gets past the initial difficulty of learning how to do the task. The rest of the application isn't very difficult at all, and I've worked with technicians, for example, who had minimal training and did just fine as long as they were under adequate supervision. So, but the field is pretty much unregulated at this point. The only regulation I'm aware of is that in Texas, in order to work with people who have workers' comp insurance, there is a requirement that you be BCIA certified in biofeedback if you're going to do any kind of biofeedback intervention for those people. But otherwise, it's an unregulated field, and individual practitioner competence varies all over the map. All sorts of people just buy a system off of the internet from eBay or anywhere else and start practicing neurofeedback. There are franchise systems now, these Brain State International. No, it's not Brain State International. It's Brain State Technologies. Brain State Technologies doesn't have any requirements for practitioners. You could be you could own a nail salon. You could own a hair salon. You could be a massage therapist. All perfectly fine professions, but not necessarily qualifying one to do neurofeedback. And their system does everything for you. It does the assessment. It does the determination of what kind of training to do. It administers the training somewhat automatically, and the practitioner is kind of out of the loop. However, if the client has a negative reaction, the practitioner is the one who's going to be in the line of fire rather than the people who are selling these franchises. The franchises are very expensive, and the practitioner has to pay the franchise company a fee for every single client they see. So there is an increasing proliferation of these kinds of approaches, and there is, again, no oversight, no regulation of this. And as we've seen from the article that we read, that people can be harmed by this approach, and these are some of the effects that people have reported. People experience agitation. Some people have experienced panic attacks, manic-like behavior, headaches, nausea, fatigue. Sleep disturbances are very common, as are headaches. Anger and irritability responses are fairly common. Crying and emotional lability is also quite common. I've never had a client have any incontinence problems as a result of, although actually I have had clients report an increase in bedwetting in children under certain circumstances, so that is a possibility. Increase in depression, decline in cognitive function, people feel foggy. I wouldn't say that it's a permanent decline in cognitive function, but certainly people will report having a little bit more difficulty with processing cognitive activities. Increases in OCD-type symptoms, that's not unusual. Increases in somatic symptoms, tics, twitches, seizures, slurred speech. I've never seen that happen as a result of neurofeedback training, but it's been reported. Reversal of gains, if you had some improvement from some other intervention and now you did neurofeedback and you lost ground, that would be an indication that the neurofeedback might be associated with that reversal of gain. Temporary disorientation or dissociation is not unusual. But again, as I've mentioned many times in the past, all of these are very temporary responses and are an indication to the practitioner and to the client that something needs to change. The approach, the training approach needs to change. And usually any of these symptoms should show some characteristics during the session. In most cases, most people will report during the session that they don't feel well. They're feeling agitated. Or you as the practitioner can pick up on that by watching their body language. If they're tapping their foot, if they're jittery, if they're getting agitated, if they're becoming irritable, if a kid says, "Oh, I'm really tired of this, I don't want to do this anymore," and it starts appearing to be angry, then it's very likely that the training approach is either contributing to that or causing it altogether. And so that would be the opportunity to make a change in the training approach. Persistence of these kinds of problems is only going to happen if the practitioner is not paying attention to the client and is continuing to proceed with a training approach that's not helpful for that client. So an attentive practitioner will not have these problems. And in my practice, I never see any of these problems occurring for more than just a few minutes during a session. And then I'm changing the training approach, and in almost every case, resolving these issues during the session. I almost never send anyone home with any kind of negative effect, except possibly headaches. Sometimes we're not unable to get rid of a person's headache during a session and they'll leave with a headache, but these are usually people who have pretty consistent headaches anyway. So what kind of clients, as a new or recently trained practitioner should someone work with. So a relatively easy condition is ADHD, and the reason for ADHD, a true inattentive frontal slowing ADHD, being a good person to work with, is because these folks tend to be fairly resilient in the sense that they don't shift out of being under-aroused very easily. And so it takes a lot of sessions. There's a lot of intervention that you have to do. They move very slowly out of this state of being under-aroused. And so generally speaking, a person with a correct diagnosis of inattentive frontal slowing ADHD, high theta-beta ratio, generally that kind of a slow pattern, will be a fairly good candidate for training. And it'll give you a lot of practice because they tend to need more sessions. The problem with ADHD is it's very commonly misdiagnosed. And the inattentive ADHD is often misdiagnosed when in fact the person actually has an over-arousal kind of ADHD. They're hypervigilant, they're overly focused, they don't respond correctly to stimuli. People call their name and they don't respond. Well, that's because they're not attending to that because they're inwardly focused, but it's an overly focused state rather than an unfocused state. And so if you train them the way you would for an inattentive ADHD person, then you could have problems. Again, if you're doing an adequate assessment that we talked about in class, then you'll see those findings being different from what you expect for an ADHD inattentive type, and you will adjust your training approach to fit the person's presenting condition rather than some presenting diagnosis. Additionally, even people who are properly diagnosed as inattentive ADHD may have all sorts of comorbid conditions that may not be the best choice. Absence epilepsy, for example, is commonly comorbid with ADHD. The presence of Mu rhythm is commonly comorbid with ADHD and may represent a mild autistic spectrum presentation. So there are also sorts of other possibilities that may show up in conjunction with ADHD. So relatively easy, but also with cautions. Insomnia is the second one that's relatively easy to work with, and these are generally people with fairly simple insomnias that are associated with situational problems. A person moves to a new city, get a new job, they start a new school, they have a new responsibility, they have a new child, they get married, divorced, things change in their life, they're having problems sleeping. Those kinds of sort of limited short-term insomnia problems are usually very easy to work with and usually are associated with a temporary state of over-arousal. Maybe the person tends toward over-arousal anyway, but they manage it well, but in this case they're not managing it as well and they need a few extra tools to help them figure out how to manage their state a little bit better. And so, again, insomnia may be a symptom of an underlying disorder, such as anxiety, depression. Sleep apnea, for example, is very common. Or even a nocturnal seizure condition can cause problems with sleep. And so somebody might come and say, well, I have problems staying asleep. Well, they're possibly being awakened by some sort of nocturnal seizure event. And so a good assessment is going to be helpful for that. Long-term chronic insomnia will have caused all sorts of physiological changes. The person will have become very used to not sleeping, and their self-perception of their sleep is going to be skewed quite significantly. Most people who say they don't sleep are incorrect. It's almost impossible not to sleep. What often happens, though, is that they sleep for very short periods of time throughout the day, and sometimes they are essentially offline or asleep at times when they think they're awake. Maybe they're sitting watching a television program, and they come in and out of consciousness because they're so exhausted that their brain and their nervous system falls asleep at every opportunity, but it also isn't a sustained sleep. So they are having a problem with sleep. But to say they're not sleeping at all is probably incorrect. And so you can work with them as well. Anxiety generally is fairly easy to work with. Again, particularly if it's situational anxiety for a specific cause. Again, the same kinds of causes that might cause insomnia. Move to a new city, get a new job, a new relationship, a new responsibility of whatever kind, a new school. All of these can trigger a very normal anxiety response, and the person just needs some additional tools to deal with that. So, for example, just some HRV training, some general relaxation training might be helpful, some alpha-theta training, some calming, relaxing kind of training might be helpful, giving them a home relaxation CD to listen to. Use of an audiovisual entrainment device may be very helpful. So again, anxiety tends to be an easier task. Most people with anxiety will respond fairly quickly. Sometimes people with a very long-term anxiety have become very much identified with that anxious state and have a difficult time with not feeling that because it feels unusual or odd to them not to feel anxious. And even though the training may elicit a response that is a complete relaxation response and they may feel quite relaxed, it often feels very distressing to them because it just doesn't feel right. And again, comorbid conditions or possible other underlying causal factors like personality disorders, PTSD, and again, chronic structural physiological changes can have happen because of PTSD. A person can experience severe physical debilitation and exhaustion, physiological exhaustion related to adrenal exhaustion. So again, a good assessment, a good intake evaluation is essential for determining whether these are good people for a beginner to work with. Now, farther on down the line, one may find that they feel completely competent working with these folks. And if you're already working with people in with these kinds of conditions, for example, severe abuse or personality disorder conditions or PTSD, already in your professional career, and you know how to work with these folks, then adding neurofeedback can be very helpful. And so you already have skills for helping them deal with this, but the addition of neurofeedback can be quite helpful. Again, it may seem counterintuitive, but migraine headache clients are often very good clients to work with for beginners. Not absolute complete beginners, but after you have some familiarity with your equipment and feel fairly comfortable with your equipment, working with clients with migraines can be a very useful thing to do. And that's for several reasons. One is people with migraines are excellent self-reporters. They're usually very highly tuned in to their symptoms, how they feel moment to moment. And as you're training them in the moment, they can tell you, I feel worse, I feel better. And they're usually quite accurate and quite responsive to those kinds of questions. And if you give them a scale, 1 to 10, for example, they'll usually be able to tell you with very subtle nuances if they feel better. They'll even say, well, I'm at a 6.5 now, and I was at a 7 before. So they tend to be very perceptive about how they feel, and that really helps you guide the training process. If you're doing an intervention and they say, I'm getting worse, then you change the intervention. And if they say, oh, that's better, it's probably quite likely that they are actually better. And they'll give you that information pretty quickly, so it helps guide your process. They're also very committed to the process, and they will usually stay with the process very consistently because they're really motivated to get rid of these very debilitating symptoms. Now, of course, the problem with a migraine, particularly an adult onset migraine, which is very unusual, is that it's more likely, if it's adult onset, to be the result of a head injury or possibly even a brain tumor. So it's important that the person has had a very thorough medical workup. That's true of all of these conditions that we've talked about, but particularly for people with migraine. It's very important that they have a good medical workup. Most of these folks have had extensive medical workups and have seen everybody and their brother. And so they've already been worked up quite thoroughly, so you shouldn't have any problems with that. But if they come to you and say, I just started getting migraines in the past month or two, and I'm 40 years old, well, then you want to send them to a neurologist for an assessment first. Optimum performance applications can be a very good group of people to work with. They're already fairly high functioning, at least in their specific field. Now, the problem is often that, yes, they're great athletes, but they're terrible in terms of every other aspect of their life. Or possibly they're great athletes and they've had multiple concussions, and now their interpersonal relationships are affected by their impulse control problems because they've had frontal brain damage and their executive function isn't working well. Their ability to be aggressive and hit people on the field is unimpaired, or maybe even enhanced, but their ability to not hit people outside of their field activities is maybe impaired. So, and of course, anybody who is an optimally performing individual in one area of their life could have a train wreck for the rest of their life. So I think it's a bit dangerous because one of the areas that is presented as something that minimally trained individuals could work with would be optimum performance applications. But many people who come seeking optimum performance training are people who have severe underlying psychological and neurophysiological conditions that they don't want to address. And so they're coming to neurofeedback because it's not psychotherapy, and the last thing they want is psychotherapy. What they want is something non-psychologically oriented as a way of resolving their psychological issues. And what they possibly need is psychotherapy in addition to neurofeedback. So those are some cautions of folks that have optimum performance aspirations. People who are difficult to work with, that I would recommend you not work with, at least until you're pretty comfortable with your program of training. Seizure disorder clients I would not work with. In fact, I don't work with people with seizure disorders. The problem with seizure disorders, as with all of these kinds of difficult presenting conditions, is they're often very delicately balanced on their medications. And if you do neurofeedback with them, it's going to change their response to their medication. And if I was in a neurology clinic where the neurologist was overseeing the medication management at the same time as I was doing neurofeedback training, I would feel much more comfortable with the process. The other thing about people with seizure disorders is that in many cases they come to you after everything else has failed. They're often end-stage chronic, poorly managed, or they've had multiple interventions. They've had their corpus callosum severed, they've had multiple neurosurgeries, they're on experimental medications, and again, they're not somebody that is in a stable condition that you would want to start working with. The second group of very difficult presenting conditions includes bipolar disorder. Again, these folks are generally very delicately managed on their medications, if at all, even if they have any sort of management at all. They may be also very resistant to taking their medications because they don't like the effects of the medication. They often have comorbidities. Anything that you do with them is going to throw them in one direction or another. They tend to be fairly volatile, lack state regulation, stability, or resilience, and so they're often easy to shift in the wrong direction. And so you can shift them into a hypomanic state or possibly a depressed state, and then they may become suicidal. And again, it's not a group that you want to work with without a lot of backing. I would rather work with these folks in an inpatient setting where I could see them every day, where there was a psychiatrist managing their medication and titrating the medication based on the changes that they saw from the neurofeedback training. That would be my choice. Any instability is often inherently more difficult to work with because they're going to respond in ways that you don't expect. So you might be doing beta up training that you would expect would activate the person, and they may have exactly the opposite effect, or they may have a much more pronounced effect than you were expecting. They start out feeling depressed and you do a little SMR training and they end up being in a hypermanic state. And so that's, excuse me, one of those cautions. Another group that is very difficult to work with is the behavioral and substance addiction disorder group. There are a lot of reasons for this. They become very attached to their addiction, very identified with their addiction. They're often poorly motivated. An outpatient setting is not ideal. Neurofeedback by itself is not a standalone solution to these problems. These problems require a good intervention strategy, including in or outpatient treatment, ongoing counseling and follow-up, post-treatment care, a support system in place. All of these, if all of these are in place and working well, then you can use neurofeedback as an adjunct to these, as long as you have some knowledge and experience in this area. But these folks are can be very manipulative, and they learn that because of their addiction. And their physiology, their brain physiology, is functioning in a way that is out of their control to a great degree. And so they behave in ways that, even though they may be a very nice person intrinsically, the addictive process has caused such changes in their central nervous system that they don't have control over their behavior, appropriate control over their behavior. So they'll say one thing and do all sorts of different things. Depression is also a fairly difficult group to work with. People who have a major depression, particularly a chronic major depression, is likely going to be in some ways, again, physiologically based, neurophysiologically based. It may be that the medications that they've been prescribed are also causing effects that may make it difficult for you to do your neurofeedback training. And when you do neurofeedback training, their response to those medications may change, and it may be not easily caught by the practitioner and the physician. And so this is a difficult group. There's also often a very strong habituation effect from the antidepressant medications. And so the changes that occur may suggest a reduction in medication dosage, but that has to be handled carefully by the physician over a period of time, and that also may put some roadblocks into your training process. And then, of course, there's the issue of secondary gain, because people with depression often have other family or life-based issues that are masked by their depression. So it's important for us to carefully assess our competence and not accept clients that are beyond our level of expertise. And also we need to provide clients with appropriate scope of practice documents, informed consent, and professional supervision information depending on where we are in our process. So how do we go about doing the informed consent? And given that, at least according to the insurance industry and most of mainstream medicine, neurofeedback is investigational or experimental, how do we reassure our clients that we're doing an ethical practice, that we are covering our bases, and that we are not subjecting them to unnecessarily experimental approaches. So we are working with what is considered an unorthodox or a new therapy, even though it's been around since the 70s, 40 years or better. It's still considered investigational or experimental. And so in the past, it used to be that everybody, or pretty much everybody, the kind of the mainstream of the scientific community in that area of practice had to be on board with this particular intervention. Otherwise, it wasn't allowed. Things have changed, and now it has to be received by a respectable minority within the relevant scientific community, and that respectability and acceptance is judged by the relative respectability of those who support the new therapy. And so they have to have adequate qualification, publication history, and standing in their field. And we certainly have that within the field of neurofeedback, where we have many individuals working in academic institutions with good qualifications and good publication history and high standing in their field who accept the use of neurofeedback for a variety of interventions. So that's been demonstrated already. There have been studies demonstrating efficacy. And so it doesn't require general acceptance from the relevant medical or psychological community to be an acceptable intervention. Now, when you do an informed consent document, there is a sample on your flash. In fact, there's a couple samples on your flash drive. One is a sample from me, which is a single page, which is somewhat minimalistic. It probably should be a little bit more comprehensive. Then there's also a 10-page one that's from Corey Hammond that's massive overkill, which most clients probably will not read, and therefore is not a good choice for an informed consent document. It's exhaustive. It covers all the bases, and in that respect it's a good document. But the fact that most clients won't actually read it means that it's probably not the kind of document you want to use in your practice. So informed consent requires full knowledgeable disclosure. That means the client has to be able to understand what it is that you're going to be doing. If they don't understand it, they can't adequately agree to it. It must be voluntary. They must be competent to give consent. The document has to be written in such a way as that they can actually comprehend what it's saying and that they'll actually read it. And it involves an ongoing process that continuously employs the above factors. So the event model of the informed consent is that you get them to sign a document. And the document has to be readable and clear. The standard is supposedly a 7th grade reading level. Has to state what the training is, why the training will be conducted, the possible side effects, a list of alternative treatments that could be used for the same problem, information about what may happen to the client if they do not participate in the training, if they decide to not utilize your services, and a short list of publication references. All of these are suggested as components of the published printed informed consent that you have the client sign and take with them. You might also want to include the extent of scientific validation, what professional organizations are supportive of this approach, scientific studies again, a more comprehensive list or a source for getting that list. Of course, the statement the client has been informed has gotten a chance to ask questions and given a copy of this. An indication of when you might be required to release this information to a court, for example. Estimate of number of sessions, fees, estimate of total costs, and then a signature. The process model, however, first of all assumes that you've got an event-related model, which is that somebody has signed a document. But even in the face of not signing a document, or even if they have signed a document, it's important to also chart on a day or session-by-session basis that the client has continued to agree to continue to participate in this training approach. And some people, if they're using paper charts, will have the client actually initial those statements. So every time I see a client, I say, so this is what we're going to do. You're okay with continuing to do that? They say yes. I make a note in their chart indicating that, yes, they have agreed to do that. And so if they were to come back to me and say, well, yeah, I heard the thing at the beginning, but then he never said, he just kept on doing stuff and didn't ever say what he was doing or ask me if I wanted to continue, and I felt like compelled or like I had to keep on going even though I didn't want to, that kind of charting note will indicate that that's not the case. I was going to sue the neurotherapist, but then he changed my mind, and if you'll note, this lady has some stitches in her forehead. So hopefully, actually, neurofeedback, biofeedback in general are very, very low on the scale of being bringing lawsuits. In fact, there have been very, very few lawsuits regarding biofeedback of any kind, and professional liability costs for insurance are very low. Hopefully we don't resort to this kind of approach to get our clients to avoid suing us. Let's talk about insurance billing, number of sessions, and things like that for a bit. Most people train once or twice a week. Most people feel that twice a week training is optimal because most people will hold the gains from a session for 2 to 3 days, and then the gains will start to diminish. So if you're training twice a week, that kind of gets you into that 2 to 3 day range. Most training sessions last 20 to 45 minutes, depending on the age of the client and the kind of intervention that's being used. For example, for 2 or 4 channel Z-score training, I rarely go over 20 minutes because the Z-scores tend to shift in the wrong direction after about 20 minutes. But for alpha theta training, I'll likely do 40, 45 minutes fairly commonly. I have done, and people do quite frequently, twice a day, 5 days a week, intensive training programs for addiction disorder clients. I've done that for summer school intensive and for out-of-town clients. They'll come in and do a session twice a day, 5 days a week for a week, staying at a hotel somewhere, seeing the sights, and then they'll go back home and maybe use an AVE device at home, audiovisual entrainment device at home on a daily basis, and then come back in another month or 2 and do some more neurofeedback training. This approach is particularly useful in addiction disorder programs where you want to get as many sessions in as possible in as short a time as possible. And so twice a day, 5 days a week, intensive training is quite useful for that. I generally do 1 session a week just because most people are paying out of pocket and can't afford any more than that. And then the additional time is taken up by doing a AVE device daily at home. And so that takes the place of that 2nd session per week and helps solidify the gains and maintain the gains between sessions. The CPT codes that you can use in your practice include the ones shown here. If you are a medical practitioner of any kind, a nurse practitioner, physical therapist, occupational therapist, physician, then you can use a chiropractor. You can use 90901. That's the code for a medical use of neurofeedback with a medical diagnosis. So 90901 is the correct procedure code for that. If you are a psychotherapy professional, licensed professional counselor, licensed psychologist, licensed clinical social worker, then you're supposed to use 90875 and 90876 for a 25-minute session and a 50-minute session. This is biofeedback-assisted psychotherapy. And so it's the use of biofeedback in a psychotherapeutic setting. Now, people do bill just for psychotherapy and provide biofeedback as a component of that psychotherapy, feeling that the primary intervention is psychotherapy and the biofeedback is just an adjunct. I'm told by people who supposedly know what they're talking about that that is insurance fraud. That if there is a code specifically for what you're doing, then you are required to use that code. And if you get paid for psychotherapy, and it comes back to the insurance company that you were actually doing biofeedback while doing psychotherapy, and you didn't use these codes, they will ask you to pay back that money. Generally, insurance companies do not pay for these codes. So they require you to use them, but they don't pay for them. And you can draw your own conclusions about that. Some people are using these codes for neurofeedback. These are mental health professionals using these codes, which are behavioral medicine interventions by a psychology professional. These are codes for using a behavioral medicine intervention by a psychology professional. So this is the behavioral assessment, the monitoring, the treatment itself, and then the reassessment code. And some people are successfully using this and defending it against any questions that it's not an appropriate code. If you're doing continuous performance tests like the TOVA or the IVA, this is a code that has worked quite well. In fact, in my particular practice, I can use this code, and sometimes this is the only thing that gets paid for. If you're going to do quantitative EEG, these are 3 codes that I have used in conjunction with each other for a single quantitative EEG assessment. So this is an extended data collection code, 95816. This is a digital analysis of the EEG code and a reference EEG database access and comparison code. So the combination of all 3 of these I bill and come up with my total cost for a quantitative EEG report. The standard answer when people say how long is this going to take, how many sessions, is 20 to 40 sessions. That's pretty standard. People will say, this is going to take 20 to 40 sessions. More sessions for more severe conditions, autism spectrum, Tourette's syndrome, brain injury, seizure disorders, bipolar disorder, chronic depression, all of those more difficult and more complex presenting conditions are likely to require more sessions. Now, these days I rarely go more than 20 sessions. I almost never see a client for more than 20 sessions. It's very unusual. So this idea of 40 sessions is kind of moving in the direction of fewer sessions. When I first started doing neurofeedback, sometimes we were doing as many as 200 or 300 sessions with a client. Lubar's early studies showed 100, 200, 300 sessions sometimes. And certainly 60 sessions was not unheard of back in the early days of neurofeedback training. And my sense is that we were not as precise. We were doing training that was sort of generally helpful and caused or resulted in some very nice results, but it wasn't optimum training, wasn't optimized for the client. So now that we've become more precise and more skillful at applying the technology appropriately for each client and more specifically for each presenting condition, the number of sessions is decreasing significantly over time. How do you know when the client is finished? Well, of course, when they come in with certain therapeutic goals, like I want to get rid of my migraine symptoms, I want to get rid of my depression, I want to get rid of my anxiety, I want to sleep better, I want to get better grades in school, then, of course, when they have reached those therapeutic goals, then you assume that the training has probably completed its task. If you're doing continuous performance testing or any other testing, objective testing, then when these measures are normal, that again suggests that the training has completed its desired goals. And when the physiological measures, if you repeat your assessment test like the clinical Q or a quantitative EEG and the measures are normal, then you assume that the client has returned to a more normal state. Now, it can be helpful to continue to train the client beyond the point where they feel that they've reached their goals, because some people used to call this overtraining, but it isn't really overtraining, it's really training to mastery. A person can learn a skill at a basic level, which will probably help them significantly in terms of their ability to function, but they may not have mastered those skills to the point where they can continuously use them even under stressful and challenging conditions. So it can be quite helpful to continue to train to the point where the person has developed a level of mastery. Additional interventions, I commonly use audiovisual entrainment, as I've mentioned. I rarely use cranial electrical stimulation, although I do use that for my clients with addiction disorders as a substitute for their drug of choice, if you will, or their behavior of choice. It isn't really a direct substitution because it really doesn't have any habituating or dependence sort of characteristics. In fact, it can be tricky to get people to actually use it consistently, but it does take away the craving pretty significantly. And so if you can get people to actually use it when they have a craving, it'll generally stop that craving from happening, at least in the short term. It's not a long-term solution. For that, they require, again, good treatment, good aftercare follow-up, good support system, and neurofeedback training, but it can be a useful adjunct. Direct current transcranial stimulation, I don't use this. It is something that people use, and there have been some positive studies indicating that it is a potentially useful or positive approach. But what has happened more recently is that in some longer-term follow-up studies of transcranial DC and also transcranial magnetic stimulation, that the effects are not lasting after the training is over. That the effects can be positive during the training, but they don't have a lasting effect. So that's what the current crop of follow-up studies seems to be showing. I refer out for psychotherapy, nutritional counseling, developmental optometry, and auditory retraining. Very commonly, children who come to see me for ADHD actually have a visual or auditory processing disorder, and if I identify that through my assessment, then I will refer them out for developmental optometry training and auditory retraining. Now, I do clinical mentoring, and this is my contact information for that. Feel free to contact me if you have any interest in that. And this is just a slide for Lake Superior. Okay, I'm going to unmute everyone so that we can have questions. So, again, anytime we're doing these presentations, it gets very confusing because of the online format to have questions during the presentation. But hopefully, if you have questions, you thought to write them down and save them for the end. So, any questions?
So for treating sleep disorder, I found it pretty easy for most clients, and I wondered, John, if you had an idea for someone who's bipolar type 1, and just before he always goes into his manic state, he starts having trouble sleeping, and it's like he stays up all night, and I was wondering if you had a protocol that might help with that.
Well, the training under the eyebrow, under the right eyebrow, the location is called FPO2. Mm-hmm. Something that Seaburn Fisher came up with, and she's got a book out about it. It's called something about developmental trauma and calming the fear-driven brain, and it's Seaburn, S-E-B-E-R-N, Fisher, just like you'd expect Fisher to be spelled. And that's a really good location for turning off the limbic system. And what you do is train, what I do anyway, I think she experiments with different frequencies for different clients, but what I do is I usually train 6 to 8 hertz as the reward, and I inhibit 2 to 6 to keep the person from falling asleep, and I inhibit high frequency. Actually, I inhibit 13 to 36 hertz just to keep all the busy brain stuff away. And what that does is it tends to calm the limbic system, and it might even short circuit this tendency to jump into a manic state. Because, you know, my first thought when you asked that question was, well, what comes first, the chicken or the egg there? Does the sleep disorder start to show up and then transition into the manic phase, or does the manic phase start out and then cause the sleep disorder? Or is it just a component of the same thing? You know, otherwise, something like alpha-theta training, AVE training might be really useful, and also CES training might be really useful. You can there are some protocols for CES training that would tend to facilitate a significant reduction in over-arousal and a return to a more relaxed and calm state. Now, anytime you're working with bipolar clients, the problem is that anything that you do, as I mentioned in the presentation, anything you do is going to shift them in the direction that you're pushing them. You're rewarding them to become less over-aroused or more activated, depending on which part of their cycle they're in, and you can shift them too far pretty easily.
Thank you. Yeah, I had him stable for 9 months.
Good.
And then a combination of stressors just sent him off. And I think these protocols you recommend will help me.
Good. Good. Other questions?
John,
Mm-hmm.
when you mentioned training and experiencing some negative side effects, you say we have changing the training protocols. And we generally, do we actually change the type of training or just the levels that we're training at?
Say that again.
Okay. So let's say we have a high anxiety state. We're trying to downtrain alpha, I believe that. And you're experiencing some negative side effects, either some cognitive dysfunction or brain fog. Now, would you generally change the areas you're in training, or would you change would it be more surrounding the levels, like you've trained too high or too low?
Well, first of all, I wouldn't downtrain alpha to get rid of anxiety.
I'm sorry, I've trained beta. Sorry.
Right.
Yeah.
Well, it's an excellent question. And usually when I'm thinking about training protocols, my first thought is, where does this reside in the brain? So that goes back to our physiology talk earlier. What part of the brain encompasses this behavior? So if it's anxiety, well, then my first thought is anterior cingulate. Although anxiety is distributed, of course, but the anterior cingulate seems to have a really large component when we're talking about anxiety. So if the person is becoming more anxious, then I think, well, am I at the right location? But let's say I'm doing CZ, training at CZ, and I've started out with beta training or beta down training, or I'm inhibiting beta and rewarding something else, or whatever it is that I'm doing. By the way, I almost never just inhibit something. I'm always rewarding something and inhibiting something else, because then I feel like I get more bang for my buck. So if I've got somebody who's anxious and I'm trying to reward a slower frequency to relax them, and I'm inhibiting beta, then my thought is I haven't gone low enough in the reward frequency, because what I want to reward is a decrease in arousal. And so if I'm going to stay at the same location, then my first thought would be, let's change the reward frequency to a frequency that's going to elicit the response I'm looking for. So if the person's getting depressed, I might boost up the reward frequency to a faster frequency. If they're getting anxious, I might move down to a slower frequency. But then I'm also going to be thinking about location, because again, location, it's really the most important thing to be in the right place. So then I might think about anterior cingulate under the FZ location, or I might start thinking about temporal lobe structures, because those are also intimately involved in parsing, what incoming material should I feel anxious about. And so the interior structures to the temporal lobes, including the insula and the hippocampus, the parahippocampal gyrate, all of these are involved in that determination of what incoming sensory input is scary and needs to be responded to in an over-arousal sort of way. And so if I can modulate those responses, then I may have a better chance at helping the person decrease their anxiety. Does that help?
Definitely.
Okay. Now, let's see. I think we've got a question here. Long-term sleep disorders for overeducated people who use and identify with their mind a lot. Is there a good treatment for that? It's a good question.
Could you repeat it?
Sure. Long-term sleep disorders for overeducated people who use and identify with their mind a lot. Is there a treatment for that? It's a really good question, because those particular kinds of people can be very difficult to work with for the simple reason that neurofeedback is a non-cognitive process, really. I mean, there are cognitive components, as I talked about in class, but it's really about, you identify what it is you want to have happen. Let's say on the screen you identify, okay, this is the bar graph that represents the reward, so you want that to be higher, and these two bar graphs represent the inhibits, so you want those to be lower. But beyond that, there really isn't a cognitive function for the person to engage in, and it just throws them completely in a world, because they cannot understand the concept of not trying. A lot of their life is all about, effortful work that gets them what they want to accomplish. And they've been taught this from day one. The harder you work, the better you do. If you're not doing well in school, well, you're not trying hard enough. We hear these messages all day long. And very few of our inputs as children, particularly, and depending on our environment and our parents and all that, will say, oh, just, sit back and relax and it'll come to you. Well, that's just, it's outside of the realm of most people's understanding, and people who are overly focused on their intellect and their mind controlling everything have a more difficult time of that, just to start with, for any neurofeedback training. So, and they do often have a problem with sleep, because they're engaged in their mind too much and don't have much association with their body. So, actually, one of the things I do is I send them out for some body work. If they've never done it before, get some body work, go get a massage, get some nice relaxing kind of body work, do some exercise program, go to a yoga class, not a not a hot yoga class where you're trying to kill yourself in a 105-degree environment. A relaxing yoga class where you're doing things slowly and you're getting into postures and holding postures and doing relaxation training and that sort of stuff. And I have relaxation tapes and CDs that I give people. But in terms of training, again, that under the right eyebrow, that FPO2 is really good, because it goes in through the back door a little bit. People are not expecting anything that profound to happen just from sticking a sensor on your head. They're just absolutely not prepared for it. And when you're rewarding 6 to 8 hertz under that right eyebrow location, there's a direct link between the orbital medial prefrontal cortex that hangs out over the orbit of the eyes and the limbic system, and particularly the amygdala. There's a direct fiber projection to and from that location. And if you can get 6 to 8 hertz activity to increase at that FPO2 location, it means that the limbic system has decreased its output, and it's allowed the nervous system to slow down. It has an effect on the reticular nucleus of the thalamus. The overall rhythms of the brain slow down, and the person generally, if they can get into that state, feel like they're floating, or they feel like they're profoundly relaxed. and it really catches them off guard, and sometimes they don't like it because they feel out of control, and their whole thing is about being in control.
Yes, so this would teach them how to relax when they want to go to sleep, but they would be still able to, overclock their brain when they needed to.
Say that again?
They would still have all their cognitive functions when they needed to, but they would be able to relax when they wanted to go to sleep.
Yes, you're teaching them a skill. That's correct.
Yes. Yes. Okay. Cool. Thank you very much, because
Sure.
I know so many people like that.
I think we all do. We may be among those people ourselves, as a matter of fact. So yes, it's a component that is highly rewarded in our culture. Other questions?
With FPO2, is that a single sensor, and then the other sensors are ground sensors?
It's a single channel, so that, yes, thank you for asking that. It's a single channel, and I usually put the red sensor, if I'm using a biotrace system, I put the red sensor under the right eyebrow, and I put the black sensor on the ear, and usually the right ear, and then I'm putting the ground sensor somewhere else on the scalp in between, maybe at F4, possibly something like that. Just anywhere, really. Or it could be on the left ear for the ground. But yes, it is a single channel, monopolar montage. Now, actually, I do use this in conjunction with alpha-theta training sometimes. So sometimes I'll do a two-channel sum training where I'm adding the sensor at FPO2 and the sensor at PZ, and I'm doing essentially what is alpha-theta training, because it's the same reward and inhibit function that I use for alpha-theta training. And so I'm training both locations at the same time. And actually I do that a lot nowadays. Instead of just doing FPO2, I do FPO2 plus PZ, and I reward 6 to 8. I inhibit 2 to 6, because I'm trying to catch that upper end of the delta band and the lower end of the theta band to try and keep people from having abreactions and from falling asleep. Now, one of the things to pay attention to when you're doing the FPO2 training is that you're going to get a lot of eye movement artifact, and you just have to tolerate that. You move your 2 to 6 hertz inhibit up high enough, the threshold high enough, so that you're not inhibiting the eye movement, because people can't help it. The second thing to remember is you don't prep that site. It's right under the right eyebrow, just in the corner of the eye, in that tissue right above the eyelid, and it's very sensitive tissue. You're not going to prep that with alcohol or anything else. You're just going to have the person rub it with a tissue to get out any oils or any makeup that may be sitting there, and then you just stick the sensor on, and the sensor is going to tend to fall off, so you want to have the person in a recliner with their head leaning back enough and comfortable enough so that the weight of the sensor doesn't pull it off. Other questions? Okay. So we've talked about central nervous system structure, function to some degree, and professional conduct. This afternoon we're going to do a quantitative EEG presentation, and we'll go through some of the details about quantitative EEG and how to use it for assessment. And I'm going to give you a couple of examples of both the initial assessment process with the quantitative EEG and how to determine what kind of training protocols to do. I'm going to show you some examples of the training protocols used with those clients, and then post-training assessment kind of in the middle, and then the kind of changes that we made to the training protocol to get at things that hadn't changed. Some things had changed, some things hadn't changed, and so we'll cover those issues as well. And then what we did as a result of that, and then the final post-training assessment to determine whether the person was finished with the training process. So we're going to cover that. And then we'll take a break, and then we will do the, it's kind of a lab experience. Now, has anybody downloaded and installed the NeuroGuide program, or are you just planning to watch the demonstration?
I did.
You did? Okay.
I've downloaded it as well.
Okay, good. So you're going to follow along now. Okay, good. So those of you who have it, great. If you don't have it, that's fine. You can just watch the demonstration. Those of you who do have it, I'm going to move right along, and the problem is that it's likely you're going to get lost because there's a lot of things to do in the right sequence, particularly at the beginning. So if you get lost, then you're going to be able to review this after the fact, because I'm going to send you the link to the recordings, and you'll be able to go through that and stop and start the and back up and do that, so it'll make it easier for you. A couple of other things about after we're done. So I'm recording this, and then I'll send you the recording. And the other things I'm going to send you are a test, which you have to complete, and you're going to. And it has an answer sheet attached to it on the last page. You're going to print out that answer sheet, or it's a Word document. You can just fill it in with Word and then send that answer sheet back to me via email, and I'll score it and let you know what your score was. So you have to complete that. Stens will also send you a, and if somebody's typing, that everyone is hearing you're typing. Thank you. Stens is going to send you a link to a assessment, a course assessment. You have to complete that. You have to complete the test. And there are a couple of other things you have to review, presentations that you have to review on your flash drive, but that's just in preparation for the test itself. So any of those presentations that are on the flash drive, those are things that you need to review in order to pass the test, because the questions on the test are a composite of the things we covered in class, including this day, and also the presentations that are on your flash drive. And then once you've completed the test, you've completed the assessment and everything else, and Stens has all of that, then you'll get your completion certificate saying that you've got these CEUs. And also that gives you the didactic proof that you need for BCIA certification. Now, you're going to have a month after we're done. When I send you this, I'm going to give you a month to complete those requirements, and that should be plenty of time. If it isn't, I'm willing to give extensions. It's, from my perspective, I don't care. But Stens, in terms of keeping records, and BCIA and all of those folks are a little bit more, let's call them highly structured. And so they want it done in a month. But I'm happy to give you an extension if you need that. One guy from the last class was heading out of town to do some volunteer work for a month, and so he wasn't going to have any time or even a internet connection. Okay, so now I'm going to stop the recording. It's about, it's between 10:02 and 5:02. We're going to take an hour for lunch, and we're going to start back up at 1. But I'm going to start the session at 1:45 so that you can log in. And once everybody's here, I'm going to go ahead and start. So log in at somewhere between 1:45 and 1 o'clock, and we'll start no later than 1. And if people are not there by 1, well, that's okay. You can come in late and just pick up where we are at the time. Okay, so anything more before we stop?
You're going to email us the afternoon link?
Yes, I'm going to. The link is in your email, but I'm going to email it to you separately anyway. So
okay, it's the same one that was in the original email.
Yeah, it's the same one in the original email. But just because I didn't have some people's email for some reason, I'm going to send it anyway to everybody. Okay. Just so everybody's got the same link, and I will email that to you. Yeah, go ahead.
I'm sorry, but I had difficulty logging on for some reason, and I finally found it. I have no idea what I did to finally get on.
Well, the second
I'm
time
a
should be
little worried.
easier. It's usually a matter of the program installing some software on your computer or some other sequence. What's going to happen is once you click the link, you're going to get a window that's going to pop up saying Launch Application.
Right.
The button, and interestingly enough, the button that says Launch Application looks like it's grayed out. And I don't know why they do that. And the other button, which is, I think, Exit or something, is the more prominent button. And so everybody ends up clicking the Exit button and not the Launch Application button. So be sure to click the Launch Application button if it shows up.
Okay, I did. I don't know if my computer was slow or what was going on, but okay.
It's possible. It may be your computer slow or your network is slow or your internet connection.
Okay.
But that's why I give you 15 minutes to log on. So try to get connected right at the beginning of that. At 12:45, I'll start the meeting and you can log in. Everybody will be muted at that point, but you can log in and make sure you've got the connection. That'll give you 15 minutes before we start. Anything else before we end? Okay. So I'm going to stop recording.